Actually, our next speaker, PJ Baudry, is on it. If you don't mind starting maybe a little bit early for your presentation today, we can do that. Just as a kind of a transition, much of the discussion around IRBs is focused on research grants. So clearly NIH is a key funder. There are those foundations that we talked about that do fund research. But we also have a lot of data collection and program evaluation within public health. And research is actually one of the 10 essential services of public health. So quite often we get asked that question, where do you draw the line between research and public health? And we're just so very fortunate to have the Northern Plains Tribal Epidemiology Center Director, PJ Baudry, here to discuss these topics with us. Because I think when we look at research, it's not within its own silo. We have to recognize that the whole idea behind research is to get answers to help us move forward toward health equity. And the tribal epidemiology centers are just absolutely vital in that role as we move forward. So PJ, if it's okay with you, we'll go ahead and hand it off to you so you can provide your comments.
Sure, thanks so much, Dr. Warren. Can you guys hear me okay and everything?
Yep, hear you very well.
Yep.
Great, so I will share my screen and hopefully you can see my slides okay.
Yeah, see them very well.
Not my presenter notes, okay, good. Great. So thanks, first of all, so much for the opportunity to present. I was just thinking, regretting that I didn't have more time today to be able to join in on some of the earlier presentations because it looks like an amazing agenda, and I'm honored to be a part and presenting alongside some of the folks that you've already heard from. So thank you so much, Dr. Warren and Danielle, for reaching out to me and for the opportunity to share with you a little bit about our work at the Epicenter and a little bit of what we know about sort of public health activities and working with IRBs and RRBs. So as Dr. Warren mentioned, my name is PJ Baudry. I'm the Senior Director of Great Plains Tribal Epidemiology Center. I've been with the Epicenter 6 years or so, been the director for 5, and certainly have learned a lot over the course of that time. But I wanted to sort of add the disclaimer that obviously, you know, I'm doing my best to sort of represent all of these different topics today, but I'm looking forward to the opportunity to discuss and you know, share for others to share, you know, what they know and things like that as part of the presentation. So hopeful that we can have a conversation after the presentation is done. So what I'm hoping to cover today is kind of providing a little bit of background on distinguishing public health practice and public health research, because as Dr. Warren mentioned, you know, neither of those things sort of happen in a vacuum, and as public health practitioners, there's every possibility and likelihood that we might be involved in research that benefits public health. And so, you know, it's worth talking about the distinction between those two and how we as public health practitioners could potentially be involved in both or either. And then to sort of, you know, put that into perspective or to, you know, provide some concrete examples of that, I'll provide a little bit of background on the tribal epicenters and Great Plains Tech specifically, and then talk a little bit about some of the types of data related activities that we do, and, you know, closing out with how some of those activities how we approach some of those activities in terms of engaging with IRBs and RRBs through those processes. So I wanted to point out that all the information I'm going to cover in this next section is based upon a really great article that was put out by, sponsored by the Council of State and Territorial Epidemiologists called Public Health Practice versus Research, a report for public health practitioners, including cases and guidance for making distinctions by Hodge and Gostin. And we've used this for years to help understand these things, and you know, I didn't have to do a whole lot of work because they had done a lot of that thinking and processing these very complex topics, and hopefully we'll be able to represent that accurately here today. So just as, again, kind of a disclaimer, I wanted to start off with just the recognition that there's not going to be any clear answers necessarily as a result of my presentation. You know, public health practice and public health research very much are a Venn diagram, and there's no real universally recognized or precise distinction, and of course there is a lot of overlap. And so what that tends to mean is that sometimes there's inconsistency, at least that might be perceived as inconsistency. Sometimes it generates a certain amount of inefficiency, you know, with regard to pursuing those activities. And of course, sometimes on the flip side of that, there may be risk associated with sort of not adequately exploring whether something is public health practice or research. But there are some guidelines that have been very valuable to us, as I mentioned, and can give you a general idea of what to consider, and that's kind of what I'll talk about here. So first of all, some definitions which were pulled sort of right from that document. The collection, human subjects research, as you probably know, and sorry, this is redundant to what was sort of covered already. The collection and analysis of identifiable health data by a public health authority. In this case, we're talking about public health research, of course, for the purposes of generating knowledge that will primarily benefit those beyond the participating community who bear the risk of participation. So of course, research and human subjects research in particular is defined by the common rule. And that definition is a systematic investigation, including research, development, testing, evaluation, design, to develop or contribute to generalizable knowledge. It's worth realizing that human subjects or research in general isn't limited to any particular actor or setting. So, you know, everybody can conduct research, you know, whether they're in public health or clinical care or business or whatever. And the concept of public health research specifically, according to the CDC, hinges on, one, the degree to which information gathering is systematic, two, the design of the activity, and three, the generalizable nature of the knowledge generated by the activity. But some have recognized that there are problems with sort of approaching it in that way, and I'm going to talk a little bit more about that in a few minutes. But first of all, many public health practice activities like surveillance are completed systematically and routinely. Quote unquote generalizable is sometimes tough to distinguish within public health, given that by its very nature, public health focuses on populations rather than individuals. This National Bioethics Advisory Commission that sort of pointed out some of those challenges, suggest focusing on, at least from their perspective, who benefits from the activity compared to who participates or takes the risk. So for example, if the people participating are also the one that benefit, then most likely it's public health practice, and if it's different, then it may be considered research. But we'll go through some more distinguishing characteristics in a second here. So here's the definition of public health practice, the collection and analysis of identifiable health data by a public health authority for the purpose of protecting the health of a particular community where the benefits and risks are primarily designed to accrue to the participating community. And I should mention, by the way, that these definitions that I'm providing to you are an attempt on the part of the authors to sort of leave out some of those issues that they see as sort of pitfalls in this definition and try to incorporate some of the things that they find helpful in distinguishing the two. And so this may not be the definition that you've seen elsewhere, but it's sort of the definition that the authors came up with to try to help with this distinguishing process. So the problem with defining public health practice is that intentionally it's very broad. So you might have heard sort of the Institute of Medicine's definition, what we do collectively to assure the conditions for people to be healthy. And then, you know, of course, activities generally include the voluntary cooperation of individuals, but not necessarily. They can include direct clinical care, contact tracing, surveillance, evaluation, all kinds of different things. And they can be defined in terms of activities, though these could include research and authority to conduct those activities. But these don't always specify. So this is kind of the CDC model for distinguishing the two. According to the CDC, like I mentioned, public health research is intended to generate or contribute to generalizable knowledge. And public health practice is intended to prevent or control disease or injury and improve health or improve a public health program or service. And so you'll see, or kind of based on what I said, that CDC model essentially focuses on the intent of the activity. And it's maybe worth noting that, you know, even though their definition of research focuses on the creation of generalizable knowledge, public health practice can also produce generalizable knowledge as long as that wasn't the intent from the outset, at least according to the CDC. So you can see, again, some of the other elements of this CDC model. You know, the public health research has relevance beyond the study population. Oftentimes it involves information added to the scientific literature, et cetera. In public health practice, the intended benefits are primarily for the participants themselves or their community. And the data collected is needed to assess or improve public health programming services or that general health and wellness of the participants, et cetera. So some essential features of public health research and public health practice. Of course, public health research involves living individuals. It likely involves identifiable private health information. Subjects voluntarily participate. You know, if it's research, generally there's a requirement for you to document consent, whether formally or informally. And it's supported by principles of bioethics that focus on the interests of individuals while balancing the value of research to society, whereas public health practice involves specific legal authorization for the activity and a governmental duty to perform that activity sort of on behalf of the public and to protect their health. Oftentimes it involves direct governmental or one of their authorized agents' performance and oversight of the project, and that agency or individual would take accountability for the, you know, the implementation and outcome of that project. It may appropriately involve individuals who do not specifically volunteer to participate. So a good example might be, you know, participation in surveillance. You know, clinical providers are required to share you know, lab results, for example, related to certain notifiable disease conditions with the state for the sake of public health surveillance. And that doesn't necessarily require the consent of the person, you know, to provide that information. And it's supported by the principles of public health ethics that focuses on populations while still respecting the dignity and rights of individuals. So the authors of this paper that we find really useful also kind of provide some distinguishing features that can be used for decision making, and sort of what they caution you against is that there are some that have been used by others or within other models that in their opinion are sort of less definitive, and then there are some that they feel are more definitive. So the more definitive distinguishing features they tend to feel are legal authority to conduct the activity, the specific intent in undertaking the activity, who the responsibility falls on, whether it's an individual principal investigator or like I said, a governmental entity, or maybe, you know, for us it would be the Great Plains Tribal Epicenter or the Tribal Leaders Health Board. Who the benefits to the participant in terms of who benefits and how relevant the benefits are to the participants. Experimental quality of the service or activity, and how the subjects or participants are selected. Some of the things that they see as potentially not as helpful are who is performing the activity. Like we said, research and public health practice, or at least specifically research, might be independent of who is doing it. You know, certainly somebody with public health authority can still be conducting an activity that is clearly research. Publication of the results, like we said, oftentimes people associate publication primarily with research, but you'll see when you dive into public health practice that there's actually plenty of examples of you know, people publishing the results of a public health program that doesn't necessarily constitute research. Urgency of the activity, and by that we mean on its own. So just because it's very urgent to implement a public health activity doesn't necessarily mean that it may not be research that needs to be reviewed. But urgency certainly can be one of the factors that are considered. Supporting funding and resources and the data collection methods involved. So a couple of case studies that are provided by the authors that I think are particularly instructive. So one is the Pregnancy Risk Assessment Monitoring System. Some of you may be familiar with this. It's a survey for new moms who have given birth within the last, you know, 6 months or so, depending on how the protocol is being approached, and intends to try to develop information about, you know, maternal risk factors and, you know, outcomes and things like that before, during, and after pregnancy. And so this is, you know, this activity is supported by the CDC and usually implemented at the state level. And it's kind of an interesting case study because the CDC itself, who funds the PRAMS assessments, actually determined the params to be research and submitted it to the CDC IRB for review. But at the same time, they provided guidance to states that at their level, params does not constitute research and that review is not required, although some and maybe many states still submit it to some kind of IRB review. So it's very interesting, that sort of dichotomy, where CDC felt like this activity should be reviewed, but at the state level did not require that kind of review. And again, it's worth sort of digging into that a little bit to maybe try to see, how they ended up coming to that. It could be along the lines of intent or how the data is used. It could also be the authority, the state, that exploration of authority at the state level may be that the state has the authority to do this type of thing at the state level, but the CDC doesn't necessarily have the authority to impose that activity or something on people within that state. Those are sort of my opinions. It's interesting to sort of dive into that, and it's also interesting because params happens to be one of the things that the Tribal Leaders Health Board and the Epicenter have experienced and been involved in fairly extensively, and that we've experienced a little bit of that gray area. We have conducted tribal specific params, and we have consistently submitted those params activities for IRB and RRB review. But at times when we've been interested in publishing, information about how we conducted those params activities that really was intended to focus on the public health practice aspects of the params, and kind of focusing on lessons learned and implementation strategies and things like that, and not emphasizing as much the data. We still found that some IRBs were requiring extensive review of that publication, despite the fact that no data was included and no tribes were identified and things like that. And so it definitely does highlight again how we've experienced that. And of course, we'll talk about it in a little bit, but we recognize obviously that such approval is really important, and having, our tribal and organizational partners review that kind of stuff is extremely important. But it does obviously sometimes create, entropy on the part of sharing that valuable information, especially when it's focused on some of that public health practice. And so it kind of just relates back to some of those challenges that I mentioned, can sometimes be experienced by the lack of a clear distinction between public health practice and public health research. So the other example that Hodge and Gostin present is evaluating or piloting an alternative HIV reporting system. So in this particular case, a hospital system was interested in trying to pilot, like the title suggests, an alternative strategy for reporting HIV that did not include identifiable information. And essentially, the state in question, or the entity in question, reached out to the CDC for their input, and CDC ruled that it was not considered research. And part of the reason they reached out to the CDC was because CDC was funding the pilot and the exploration, and so CDC themselves did not consider the activity research. They considered it evaluation of a surveillance system. But because the entity undertaking the evaluation or piloting, explored state statutory authority and determined that there wasn't specific language within that authority authorizing this type of activity, the decision was made to request IRB review, as being outside the scope of the existing public health practice associated with that particular state. So it's worth noting that that review was, through that review, the protocol was found to be exempt from, full IRB review, but it's still an interesting case study in terms of how these types of decisions are made. And it's also interesting because, again, GPTech has experienced some of this type of thing, and I'll talk about that in a little while. So what I did actually, and we'll talk again in a little bit about, we've actually been pursuing some work recently to try to help support not just our staff within the organization, but also our partners in navigating the IRB and RRB landscape here within the Great Plains area. We've been developing an IRB and RRB toolkit. And to include in that toolkit, I actually developed sort of like a decision tree based on guidance that Hodge and Gostin provide in their article. And so this is just an excerpt of it. It actually is like incredibly long. If I included all of them, it would be, you know, it would be like tiny. But it basically takes you through, you know, it asks you a question, and then based on the answer to that question, you sort of either continue moving on in the decision tree, or you identify this is public health practice or research, things like that. So it's a helpful tool, and more than happy to share it with anybody that might be interested in applying it to their work. And certainly it's not the end all be all, but hopefully something that at least gives you some guidance to go on as you're making some of these individual decisions for yourself as you go about your work. So I'm guessing we'll probably save questions for the end. So probably won't necessarily pause right in the middle. But so I wanted to, like I said, sort of get this down to earth and sort of talk about specifics through an overview of the tribal epicenters and GPTech in particular and some of the work that we do. And so the first thing I always like to say is that the Great Plains Tribal Epicenter is only one of 12 tribal epidemiology centers throughout the country. And we're all kind of funded to serve a similar mission and to operate within or to provide, you know, a standard set of core functions, which are outlined in the Indian Healthcare Improvement Act, when it was permanently reauthorized in 2010 as part of the Affordable Care Act. And you can see that, you know, obviously these 7 core functions really do, you know, I think that the emphasis, if I had to weigh in, is mostly on, you know, public health practice, but you can easily see how research might be very much involved in some of these things, depending on, again, the intent of the activity and, you know, what we're trying to accomplish with it. So it's worth noting, and I don't want to dwell on this too much, but it's worth noting that also in the Indian Healthcare Improvement Act in 2010, tribal epicenters were recognized as public health authorities in terms of, you know, collecting and using and accessing data. And the reason I bring this up, there's a couple different things I want to mention. One is that as we've already talked about, the public health authority is very important as a factor to weigh when it comes to conducting data collection and other activities associated with public health practice. So, you know, this public health authority, to a certain extent, gives us that you know, that platform to be able to undertake some of those public health activities on behalf of our partner tribes, and with their partnership and support, and with their authorization ultimately. It also gives us the ability to access additional data that we can use to sort of add to that picture and be able to best serve our partner tribes. And that's kind of the second point, is that that I want to emphasize, and that I always emphasize when I talk about this, is that this authority is intended to supplement and support the public health authority that's invested in tribes as sovereign nations. And although, to be fair, we have experienced that, like Tribal Epicenter Public Health Authority, there have been some challenges in sort of gaining recognition for and implementing that public health authority that are worth noting, and that we've run into, you know, even as we've been responding to COVID and things like that. We consider the importance of this public health authority primarily in terms of how it enables us to do our work on behalf of our partner tribes. And that's kind of the other point I want to raise, is that GPTech also derives the authority for our work from a resolution that our tribal partners have signed off on, that you know, sort of recognizes that the work that we do on their behalf and authorizes us to pursue that work. So it's worth mentioning and being aware of that as well. So GPTech, of course, is part of, as I mentioned, the Great Plains Tribal Leaders Health Board, where our program serves all of the tribes and tribal communities here in the Great Plains area, North Dakota, South Dakota, Iowa, and Nebraska. And you'll see we have a variety of goals. I'm not going to kind of go into these in detail, but you'll notice that, you know, obviously the collection and use of timely, accurate, and useful data, as well as supporting well-designed, culturally appropriate, and ethical public health research are both elements of those goals, and sort of at the core of what we try to offer, you know, to the area. So variety of services that we offer, and I won't necessarily dwell on this, but it's worth mentioning because I think oftentimes people hear Tribal Epidemiology Center and they think of sort of a specific thing. And it's worth noting that, you know, the Epicenter does a lot of really diverse work, and that this work doesn't necessarily focus on one particular topic area like behavioral health or maternal and child health or something like that, but rather spans all of those domains with regard to, you know, the sort of implementation of public health practice across all of those different topic areas and subjects. So I wanted to talk a little bit about our perspectives on data and how we approach that. And so kind of the way that we look at it is sort of, you know, in this sort of worldview of sort of data to wisdom. So data, as it's defined, is measurements or statistics used as a basis for reasoning, discussion, and or calculation. And from our perspective, oftentimes data is raw, it's unprocessed, it may not mean much to us, at least not yet. Of course, it has meaning. It's not to say it doesn't. It's just to say that we might not necessarily know what that meaning is when we're looking at sort of the raw, unprocessed data. So information is obtained from investigation, study, or instruction, and from our perspective, it's data transformed. And by that we mean processed, analyzed, compared. It's where data begins to tell us a story. And we may not have the full context for that story, but we may be able to start seeing some of the details. So knowledge is knowing something with familiarity gained through experience or association. And this is information accumulated. It's the sum of what is known. It's where the story begins to have meaning. And finally, wisdom is the soundness of action or decision with regard to the application of experience, knowledge, and good judgment. And from our perspective, you know, oftentimes you'll hear that statement of, you know, making data-driven decisions. From our perspective, we try to, our goal in working with data is to try to promote wisdom-driven decisions, meaning that we've done the work to take that data, to translate it into information, into knowledge, to put it into its larger context and use that larger context and the wisdom that, you know, that is provided alongside that data to make those decisions at the end of the day. So, you know, to kind of take that worldview and try to put it within the lens of Indigenous data, first of all, it's extremely important to recognize and consider the historical and cultural context when collecting, analyzing, and disseminating data. And there are certainly people that know this better than I do, but, you know, things like the impact of colonization and trauma, both past and present, you know, recognizing traditional public health practices that were, you know, practiced within indigenous communities. Oftentimes, sometimes this, we also think of this in terms of, you know, and again, having that respect for what those practices are and what we know works within tribal communities and indigenous communities, not just what the data is telling us. So the other things that we recognize is that the boundaries between data, information, and knowledge may be more fluid within indigenous communities than in others. Sort of that data to knowledge cycle sometimes can be a little bit Western in nature, and what we recognize is that when it's applied to indigenous communities, we need to approach it a little bit more fluidly. So that the data, information, and knowledge is both individual and collective. And so a good example of that is that, you know, the Great Plains Tribal Epicenter, when we approach data, we approach tribal confidentiality with just as much care and consideration as we do individual confidentiality. As an example of that, individual and collective, you know, consideration. And data, information, and knowledge are not just microcosmic, but they're also cultural, they're community-based, they're interest-based. Knowledge and wisdom may not be dependent upon data. Like we mentioned, there's traditional knowledge, traditional practices that need to be considered, and within, and it's only through that lens that we should really be properly evaluating the data, you know, from an indigenous perspective. And oftentimes within indigenous communities, the challenges that we experience are inconsistent, inaccurate, or irrelevant data that's collected, external control and ownership of the data, community concern or mistrust, a lack of external support for local data infrastructure and capacity, and the deficiency of data describing indigenous peoples and lifeways. And most likely I'm preaching to the choir. I hope folks will forgive me for sort of, you know, sharing some of these points. And to unpack that a little bit, you know, there's a great article that I cited at the you know, at the bottom of the slide here that talks a lot about Indigenous data sovereignty and governance, and so I wanted to sort of unpack those a little bit for those that may not be familiar with it. So Indigenous data sovereignty, at least according to the United States Indigenous Data Sovereignty Network, is the right of a nation to govern the collection, ownership, and application of its own data, and it derives from the inherent right to govern their people's lands and resources. And ultimately, Native nations exercise Indigenous data sovereignty, at least according to Carol and her colleagues, is through the interrelated processes of Indigenous data governance and decolonizing data. And you'll see how this is kind of related to trying to address some of those challenges that we mentioned are often experienced within Indigenous data. So Indigenous data governance means harnessing tribal cultures, values, principles, and mechanisms, that is, Indigenous ways of knowing and doing, and applying them to the management and control of an Indigenous nation's data ecosystem. And decolonizing data means replacing external, non-Indigenous norms and priorities with Indigenous systems to define data and how it is collected and used. And it results in information and knowledge reflecting the understanding of Indigenous people. So obviously the sort of outcome of all of that, you know, we always, you know, keep at the forefront of our mind, whether we're pursuing public health practice or public health research, is, you know, making sure that we're, you know, keeping those things in mind, and then also following some of these best practices with regard to data collection and analysis from Indigenous evaluation and practice. And so that involves developing tools and procedures that unite community wisdom and best or standard practices. And ultimately, oftentimes that involves engaging the community and having, you know, community leaders co-lead, you know, the process of making some of those decisions about how data collection is going to take place and how data analysis is going to take place, and considering and integrating the community and culture when determining the approach and methodology. It's also important to include a focus on what is good, strong, and needed to build upon existing strengths. You know, unfortunately, sometimes, especially within the context of grants and things like that, unfortunately, public health too often focuses on sort of a needs approach or a weaknesses approach. And, you know, one of the things that we try to really focus on, which I think derives from, you know, some of the you know, some of that cultural knowledge and community wisdom, is to focus on assets and strengths and leveraging those, you know, to know what we can do. And also to keep in mind how the data could be used to strengthen community responses and generate beneficial outcomes. So, you know, it's worth mentioning with regard to data sharing that within the health sphere, of course, our relationship with data is one that's based and dependent upon trust. And I think that trust from our perspective is multifaceted, not only that the data and information are protected and that when it's shared, the purpose has been carefully considered and reviewed with the application of experience, knowledge, and good judgment, and that the risks are non-existent, minimal, or heavily outweighed by the benefits. But I think, you know, we sort of choose to believe that there's also an element of that trust that involves that data and information being used, and maybe by being used, we mean being shared, to improve the health and wellness of those communities. And again, that kind of comes back to the purpose of public health practice. So often what we are, a big part of our work, and hopefully a big part of all of your work, is to help bridge some of that data divide, and not just sort of share data for sharing data's sake, but sharing it you know, for the purposes of improving health and wellness and generating that conversation, and doing so ethically and responsibly across all of these different domains, and with, you know, input from, you know, and co-leadership from the communities involved, and all of those kinds of things. So, of course, you know, one of the things, not to sort of get preachy, but, you know, one of the things that obviously we try to keep in our mind, in the back of our mind at the end of the day, is that every, you know, behind every data point is a daughter, a mother, a sister, a person, you know, with hopes and dreams, and with, you know, that they may have experienced, you know, the data that you might be looking at may be representative of the worst moment or the worst, you know, aspect of their lives. And so, you know, we try to recognize and respect that throughout all of our work. So I wanted to end with, you know, some examples from GPTEC's activities and how that kind of relates to IRB and RRB. And so, and sorry, I know I'm kind of running up on our target time, so I'll try to kind of go through this relatively quickly. But this kind of falls into several different domains. So the first one being evaluation, tracking, and performance measurement, which generally speaking are just standard parts of public health grants in general, whether they be focused on research or public health practice. So I'll let you kind of, look at sort of how we use those. I primarily want to talk about some of these examples. So I run an STI and teen pregnancy prevention initiative working with tribes in the Great Plains, and we do a comprehensive evaluation of that program. And even though that program does fall under the heading of evaluation, we do have that reviewed by our tribal and regional IRBs for a few reasons. One being because there may be an interest in generating generalizable knowledge out of that activity, even though it's not technically research. We also, it involves, vulnerable populations, namely youth under the age of 18. And so, we want to make sure that our partners and the IRBs have reviewed that and sort of brought up any considerations that we haven't thought of in those. One of the activities that we're doing actually right now is a qualitative study focused on evaluating and synthesizing information related to policies that were passed through the first cycle of the Good Health and Wellness Initiative. And so again, even though that's sort of an evaluation related activity, we wanted to review that because of our intent to generate generalizable knowledge based upon it with our partners' input. We've done some work related to developing data tracking and reporting tools for tribal and IHS grantees associated with substance abuse and suicide prevention and domestic violence prevention programs, which is not reviewed because we're sort of just developing a tool in which they can track that data on an ongoing basis. Of course, we do evaluations of some of our trainings and meetings, and generally those aren't reviewed because A, they're anonymous, and B, we only intend to use the information from that to improve our services, not necessarily to generate any generalizable knowledge. And then finally, we've developed some comprehensive tracking systems for key activities that the epicenter pursues, like our technical assistance and our data request response activities. And I've also included some sample performance measures, which again, you're probably familiar with the fact that performance measurement is a huge part of most grants, certainly public health grants, as just a way to provide a concrete opportunity to monitor program activities and demonstrate impact. So assessment, and this tends to be one of the areas that tends to be a little bit stickier, with regard to that distinction between public health practice and research. Of course, for us, assessments are designed to generate original public health data to identify or clarify public health priorities and assets, needs, and to inform response. We want to try to maximize the probability that our programs and services are going to be beneficial for the communities participating in those projects or services, and also just try to do that through ensuring that we have guidance for our activities. We've done several of what are called community readiness assessments. If you're familiar with the community readiness model, it sort of is almost, to a certain extent, it's sort of like a rapid needs assessment of a particular domain and a community's readiness to address that based upon, what existing efforts are going on and how aware the community is of those efforts, leadership and community perspectives, et cetera. So we've done multiple of those readiness assessments, and generally speaking, especially in recent years, we've had those reviewed by the IRB, in the past, we've sort of relied on the precedent that has been found to be exempt, but in recent years, we've sort of submitted it for exempt status just to, again, get some of that guidance on that particular assessment within that particular context. We did a tribal public health assessment that comprehensively assessed sort of a variety of public health capacities and needs and priorities from tribal public health staff at the local level. And we did have that reviewed because, again, there was the possibility that we may want to generate some generalizable knowledge based upon that, and that we might want to follow up on specific recommendations and things like that. So we had that reviewed. We did a tribal training needs assessment that was not reviewed because, again, that was primarily designed to inform our activities. And then you can see there's been a couple others that we've that we've implemented that have been reviewed and some that haven't been reviewed. I'm happy to talk a little bit more about those if folks are particularly interested in one of those. Again, without sort of belaboring the point, it really comes down to the intent of the activity. It comes down to, how we plan on using the data, and, what we plan to accomplish. And then again, just our authority to undertake that activity. So for example, we did have some folks that reached out to us regarding needs and impacts assessments that we've been conducting related to COVID and that weren't IRB reviewed. And, again, what we, some of the communication with regard to that was that, this is in response to a public health emergency. And we were primarily conducting those assessments in order to guide our response activities to that public health emergency. And under our public health authority, we have the ability to undertake those activities on behalf of our partner tribes and for their benefit. And so, of course, the data that we collected, the only time we ever share that data is if it's aggregated at the regional level. And the only time tribal data is ever shared is with those specific tribes, for example. So there are some nuances associated with some of these other activities that I'm happy to go into if folks are interested in them, but assessment tends to be one that's a little bit of an interesting dynamic. Public health surveillance and reporting, of course, is a key public health practice activity, and again, one that tends to have a little bit of a gray area occasionally. We already talked about PRAMs and BRFIS and sort of some of the considerations around why we sometimes have had those reviewed. Generally, some of the data-related activities that we do, like abstracting publicly available data sources into tribal or regional reports, that just tends to fall under our authority as a public health authority to do those kinds of things on behalf of our partner tribes as public health surveillance. Whether it's mortality, infectious disease, maternal and child health, or morbidity and mortality. We've also pursued what are called EpiAids, which are essentially sort of rapid epidemiological investigations into a key issue or outbreak with the support of CDC personnel, and which can be requested by public health authorities, that being states, tribes, as well as GPTEC on behalf of a tribe or tribes. And we've conducted several of those or participated in several of those related to chlamydia and gonorrhea and syphilis. And then we recently did one related to maternal substance use during pregnancy. And it's worth noting that the chlamydia and gonorrhea and syphilis EpiAids were conducted without IRB and RRB review because they fell within that existing scope of what is considered public health practice and public health authority by the states that were involved in those EpiAids. But it happened to be that the maternal substance use during pregnancy was determined to not fall within that existing scope of public health practice. And so that one did have to go through extensive review and approval processes. And we certainly, completed that review and pursued that in the appropriate way. But we also did some advocacy around, recognition on the part of some of our states that, it doesn't necessarily need to be an infectious disease for it to be an outbreak or for it to be an emerging issue or for it to be something that needs to fall within sort of rapid response for public health. And so, that again kind of highlights maybe some of that, some of those gray areas and what we can maybe do to help raise awareness of responding to that. And of course, we have maybe to a limited extent over the years, but we have been involved in some public health research. Most recently, that's taken the form of, we have a small amount of funding from the National Institutes of Minority Health and Health Disparities. And what we've used that in recent years for is to support small tribal student research projects for the purposes of exploring the drivers of, extent of, and responses to health disparities, to promote the growth of research capacity on the part of students and fellows and things like that, and to support culturally responsive research at the tribal level. And so, we've made those opportunities available, and we'll actually be making them available again. So, we've definitely benefited from some of our, university and other partners in helping us make students aware of those opportunities so that they can pursue some of those research projects if they're interested in doing that. And as I mentioned earlier, we're also working on developing a tribal IRB and RRB toolkit for the Great Plains area to help those students working on some of those research projects, but also some of our various partners navigate the IRB and RRB process. And it's worth noting that GPTech, as part of sort of the contracts that we established with those student researchers, we require both tribal approval and IRB RRB approval prior to pursuing the project. And we expect that and set the expectation within the contract that students are going to disseminate and facilitate a discussion of the data resulting from those projects with the tribe and with community members within that tribe, to ensure, again, that part of the public health ethic that says that something needs to be done with the data, that the community needs to own and govern that data. Last couple slides, I wanted to cover specifics to the IRBs and RRBs. So this is kind of a really rough diagram of sort of our current understanding of the IRB and RRB landscape within the Great Plains, and I'd ask you not to read too much into sort of how the diagram is put together. The purpose that I'm trying to get across is that GPTech's IRBs and RRBs of record are primarily the tribal IRBs and RRBs where they exist, and then the Great Plains Area IHS IRB where a tribal IRB does not exist. So that's kind of what you're seeing here, is that, you know, certain tribes do have an IRB or RRB of record that we, you know, always apply to. And then, you know, generally speaking, if we're working with a tribe that does not have a specific IRB, we'll submit to the Great Plains IHS. And in a lot of cases, we'll actually submit the protocol to the Great Plains IHS either way, just for the benefit of getting additional review on it. It's worth noting that, at least for my understanding, Great Plains Area IHS IRB has jurisdiction in addition to tribes when IHS employees are involved in the protocol, or when IHS resources are being used to conduct the project or the research. And so as much of our funding support comes from IHS, we generally involve them in that review process in addition to tribes. And of course, when we're working with external partners like contractors or universities, we also support the approval of projects by an entity-specific IRB or RRB as well. And I want to kind of point out that, you know, while it does occasionally add additional time and increase entropy for our projects, we do generally err on the side of having our projects reviewed if there's any question whatsoever about where they fall on that dichotomy, because that ensures the proper governance of the data collected and the proper review of those activities to make sure that we're doing our work in the proper way. We consider tribal IRBs and RRBs especially as extremely valuable entities in terms of supporting tribal data governance and sovereignty, in that they review projects to ensure relevance, ensure tribal support for the project, and to ensure respect for cultural and local considerations. And in some cases, the IRB and RRB actually manages the return and storage of the data resulting from that project. And so, you know, we'd much rather have them take a look at it and let us know what they think than sort of, you know, not have that opportunity for review and feedback, and, you know, that opportunity to engage, that opportunity for tribal data governance and sovereignty to be exercised. So some considerations, and this is kind of what I'll end with. For, you know, those of you that may be pursuing research or maybe guiding students, from our experience here in the Great Plains area, and this may be sort of duplicative of some of the input that you got from others that presented throughout the day. I was really glad to see that, you know, folks from Tribal Nations Research Group and from Sitting Bull College were able to present, and I really wish I was able to join in on that presentation. But always build in adequate lead time for IRB and RRB approval within your public health project timelines if you think it might be necessary, or if you think it might be beneficial. It's definitely something that we've experienced. You know, is that the review process can definitely take time. You know, some IRBs and RRBs rely on volunteers. And of course, as a result of that, you know, people are wearing multiple hats, and sometimes they have challenges with a quorum, or sometimes there are, you know, sometimes a snowstorm or something will impact whether or not the IRB can meet. You just never know. And so one lesson that we've learned is don't forget to build that approval process into your timeline for your project, because if you don't, odds are you'll be behind the curve from the get-go. Develop a working knowledge of each IRB and RRB's submission and review schedule. Know when those deadlines are, and then know when it's going to be reviewed, and sort of know what to expect with regard to that timeline. And make sure that you have a working knowledge of what each submission is going to require, because the last thing you want to do is spend a lot of time working on a submission and then have one document be missing that requires the protocol to be tabled until the next meeting because something was missing. And so do your homework and reach out to those IRBs and RRBs and find out what they need, find out when they need it by. And like I said, we're hoping to help with that process by developing that Great Plains Area IRB and RRB toolkit for reference by some of our tribal partners, and in collaboration with the IRB and RRB leads and coordinators at the local level. Consider, especially if it's regard to public health, consider applying for expedited or exempt status if the project is likely to qualify. I'm not sure if that was covered throughout the day today, but if it wasn't, happy to kind of cover that a little bit more if folks have questions. But essentially, obviously, that just means that maybe it's not reviewed by the full board, or maybe it's determined to be exempt and doesn't even need to be reviewed at all. Not every IRB and RRB have a pre-screening process for expedited or exempt status. But it's worth, exploring that, and if it's available, applying for that if you feel like it would apply to your project, because it can save time. And obviously it saves not just your time, but also the board's time in reviewing a project that doesn't necessarily need to be reviewed. And then if the opportunity or the option is available, request and take time to attend the IRB or RRB meeting, whether it's in person or by phone, for discussion of your protocol. Obviously, the meeting might not be open for you to participate in the entire thing, but first of all, it's a great learning opportunity to understand how IRBs and RRBs work on the ground. And second of all, we've found it's a great opportunity for us to answer questions right away, which can significantly expedite that review process. What we've found is that for some IRBs or RRBs that don't offer this option, the board will review the protocol, then they'll send us some questions, we send those questions back, and then either they have to review it again based on that new information, or they might need to take time to process that alongside other things. And so if you're able to answer those questions right away and address any concerns that are there, it can really expedite that process. And I think, just speaking sort of bluntly and from my perspective, it also just shows that you're really engaged in the process and that you respect their input, and you want to be there to hear what feedback there is and to be able to answer those questions. And so whenever we have that opportunity, we always take advantage of it, to join by phone, to come down in person if it's feasible for us to do that, to be able to engage with those IRB, RRB members in person. So with that, just want to again emphasize that we're here to support your work however we can. Don't hesitate to reach out to us, and I hope that this has been informative. I'm sorry if I ran a little bit over sort of that, if we're thinking about this in terms of an hour, but I know we're maybe still within the original time frame. So happy to answer any questions or participate in any discussion about what I covered, or go back to anything that I skipped over or anything like that. So thank you so much again for the opportunity.
All right, well, PJ, thank you very much. That was outstanding information, and we're recording all of the presentations, and each one covers very unique and meaningful areas. But I think particularly with the things you covered, it's incredibly valuable for us to be cognizant of the difference between public health practice and public health research. And certainly that needs to be integrated into our curriculum for our students, but also for researchers as well, to understand this also from a tribal perspective. And I'm really looking forward to the toolkit, because we really need an inventory of tribal research review processes in the Great Plains, because each tribe does it differently. And we have to be respectful of each of those processes. So
absolutely,
as that moves forward, whatever we can do as a university to help support that, we want to do. And the Tribal Epicenter and the Tribal Leaders Health Board has been a wonderful partner and collaborator in a number of projects that we've been working on. We want to continue to maintain that. So just in terms of a kind of follow-up question, what is the timeline, do you think, for getting the toolkit up and running? I know you guys are bombarded with COVID and related challenges right now, but how's that coming along, and might that be something one of our graduate students could assist with potentially.
Yeah, I was actually going to say, that's a great question. We actually were so fortunate to have a student intern working with us on that project from Oglala Lakota College, or who had graduated from Oglala Lakota College. And the toolkit is sort of ready. We need to do some internal review. Basically she sort of has handed it over to us with as much as she was able to get incorporated in there. And I think we'll sort of take it and incorporate some additional information from our experience, and maybe even some of the content from this presentation and things like that into that toolkit, and then roll it out. So I think, my hope, like I said, we're going to be approaching another round of those tribal student research projects, and our timeline, our goal is usually to have those, selected and funded and sort of ready to kick off by the end of December into January. And so my goal is to try to have that toolkit certainly done by the end of December, so that we can basically hand that off to those students and help facilitate that IRB and RRB process for that next round of funded student research projects. But it's definitely a priority of ours. Like you said, it's so important to put that information out there. And I think, if anything, the consideration moving forward is going to be, how do we make sure that we're keeping that toolkit up to date, and making sure that we're incorporating new things. But that's the hope, is that, certainly at the very latest by the end of December is our goal, to have that toolkit out for folks to be able to engage with.
Outstanding. And, through the DaCCoTA, of course, it's the DaCCoTA Cancer Collaborative on Translation Activity. It's evolving into DaCCoTA Community Collaborative on Translational Activity, and looking at broader-based research priorities. With several of the projects we have moving forward with our community engagement and outreach core for research, it seems like one thing we could add to that is engaging the communities to develop tribal-specific research agendas. That's one of the things that Anita and Dr. Mongo talked about from the tribal perspectives. And perhaps as another area of collaboration is linking the research review processes to the specific community-based agenda settings. So look forward to continued collaborations.
Yeah, absolutely. I feel like that has been something that, what we've seen is that some of the tribes that have a comprehensive health plan, or things like that, they tend to be very engaged and interested in pursuing activities that sort of supplement and support that plan. And so it's definitely been something that we've done to a certain extent and incorporated into some of our more general public health assessment activities in the past, is sort of like, what topics would you be interested in research around if the opportunity was available. But I think it would be great to develop a comprehensive knowledge of that from across the region, because like you said, it's so important that those research projects are tribally driven. And like we said, that's really a precursor for these student projects, is that they've worked with the tribe to identify a topic that's of mutual interest to both of those parties, and of mutual benefit. And so I think, yeah, that would be great.
Sounds very good. Well, excellent discussion. So let's go and open up, see if there's any other questions or comments from any of the participants on the webinar currently. Feel free to ask verbally, or even put it in the chat if you'd like.
Let me see if I can stop sharing here at all. That way I can see whoever's asking the question via Zoom.
I do recognize it's late afternoon. It's been a long day packed with a lot of information. But don't really see any questions or comments. And just again, thanks PJ for all of your contributions. And I also really do want to acknowledge Danny Thompson and Arun Bhatta and all of the effort that you did to make this happen. This was supposed to be an in-person event several months ago, but of course COVID-19 changed that, and we weren't sure if this would be something that could be done virtually, because it's kind of a lot of information to absorb, and doing it all on Zoom isn't the most it's not the easiest way to do this type of event. But just thank you both, Danny and Arun, for doing such great work in getting this moving forward. But Danny, I'll go ahead and hand it back over to you. And Arun, any final comments or anything that you'd like to share regarding the recording or anything else?
Sure. Well, thank you, Dr. Warren. I really appreciate the opportunity. You know, it's fun to try new projects, even if nobody's idea of the best day ever is to sit at a Zoom screen for 8 hours. But I just want to make a plug again for the feedback survey. If you have a chance, please fill it out. We're very interested in your feedback, not only for how these events are structured going forward, but if we can be a nexus for connecting you with somebody that you saw their presentation and were really interested in it, but maybe aren't necessarily in their sphere to connect with them. So please allow us to connect you with the people that you're interested in communicating with. Our goal is to generate ethical, community-based research that is really effective and beneficial for communities and for the research community in a larger sense. So we've hit a lot of concepts today, from sort of the growing your own. We need more researchers that are based in communities that need more research. Also teaching, sort of traditional researchers how to engage effectively with tribal RRBs, IRBs, working with communities to establish beneficial relationships. And then on top of everything else, how that's going to look with COVID on the side. So we're really interested in creating relationships and helping everyone else navigate to the right resource. We might not be the best place to work with, but we're the best place to start. At least we know people. So we're really hoping that we can utilize that ability going forward. But thank you all so much for coming. I will be parsing out each individual session into its own video. I will be reaching out to presenters at a later date to talk about if they want to apply this to CME credit. And there's a couple extra steps we have to go through in that regard. But we'll make these available online once I can do the tech stuff with it. And we'll be available for questions or feedback or connections as you need.
Very good. And there was one question from Reno Charette. She's the executive director for AHEC, the American Indian Higher Education Consortium, which is represents all of the tribal colleges and universities nationwide, and looking at whether or not student workers on projects are advertised or if there's notices. And PJ did respond, yes, that they do have them through the health board, and certainly through our growing community engagement core for research here at the School of Medicine and Health Sciences. I think that'd be a wonderful relationship with the Tribal Epidemiology Center, AHEC, and the university to work collaboratively to make sure that students, PhD students and tribal college students across the board have access to these experiences, because it'll only strengthen our capacities in the future. So thank you, Reno, very much for that question.
Well, and I think that brings up an excellent point. We've talked a bit today about getting at the source of the information, what's actually needed, what's actually wanted. And I'm always about ideas for the next thing, but currently the RFAs that we have at DaCCoTA require a terminal degree in the field. I don't think that prohibits a discussion about, can we create some sort of funded opportunity to maybe provide student leadership on some of those projects? We have students available, they need projects to do. And perhaps there's a supervisory element there, but clearly, with Reno, with PJ, we're utilizing students, but maybe just not enough or as well as we could be. So definitely a conversation I want to have at some point. So I'll cue everybody in.
Very good. In the future, we'll have tribal college students, graduate students, and medical students working side by side on these projects. I think that's a great goal. Yeah. All right. Any other last comments or questions before we break for the day? Looks like we'll give you about 12 minutes of your time back for today. All right. Well, thanks, everyone. Really appreciate it.
Thank you.
Thanks. Be well.